Hello, my name is Peter Fritz, and I'm a periodontist in Fonthill, Ontario. Over the last few months, I've been deeply interested in how the specialty of periodontics and the future of dentistry and dental hygiene will look when we emerge from this pandemic and state of emergency. I was among the first dentists in Canada to contract and recover from COVID-19, and now I'm ready to share with you a strategic approach to protect your patients and your staff from getting sick. The purpose of this presentation is to help you guide your non-surgical team to being the most effective in the new world. It's not the only approach, but it is remarkably simple, and it depends on people. The internal evidence is irrefutable. I've lived my life with one mantra: never stop learning, because the world around you never stops teaching. Today, please let me update you on what I've learned and the power that may bring you. This is a story about an uncomfortable truth about dental teams. There's an awful lot of hysteria, panic, and negativity about regulations, guidelines, and best practices. Suddenly, everyone's an expert, and this can be dangerous, as personal biases can confuse the reality of science and experience. But the solution is remarkably easy. Innovate. Change the way you think about non-surgical periodontal therapy, and accept the fact that you must move forward and things will be different. We're trying to align our teams, but many are on different levels. And this is understandable. We are trying to figure things out, how to do things, but it's tough. It's uncomfortable, it's unfamiliar. And it's up to you to lead your team through this. Well, I'm going to make it a little bit easier for you and your teams to find common ground. The first thing one must understand is that in a crisis, there are different levels you can be on, and we aren't all on the same level. You start the crisis in the basement, and this is the panic and fear stage. You run to the basement and you hide in the darkness. You feel threatened and scared. There's irrational behavior. You start hoarding things like toilet paper and food supplies. You watch and consume all the media and all this information that comes around us. We spread anger, and we spread a lot of those negative feelings. It's not a great place to be in. It's a terrible place to be trapped. The next stage is the learning stage. This is the main floor. You can see the light, but you don't have a helicopter view of the world. We stop spreading anger, and we accept a lack of control. We try to filter our emotions, and we gain some kind of maturity of the situation. You see, the next best thing to control is flexibility. Finally, we move to the growth stage, the top of the building, where you can see the sun, and we have a holistic overview of the world around us. Suddenly there's hope. We show empathy and make ourselves available, and we demonstrate adaptability and sense-making. And you can move very quickly from one step to the other, and you can take your family or your team through these changes. And it's possible to go up a level, and it's also possible to go down. People talk about bouncing back. I have the least interest in bouncing back. I want to bounce forward. I've spent my career traveling with my team to over 40 clinics in 25 different countries, benchmarking best practices in some of the leading specialty clinics in the world. Maybe I've been to yours. What we've learned is that there's considerable variation in best practices due to regulations, cultural differences, and university training. The external evidence and the internal evidence are often in conflict. What's universal is that all the leading clinics want their patients and their staff to feel safe and well supported, and for their patients to receive the best possible care. Safety is the critical element that you can't cut corners on, but safety regulations, unlike gravity, need to be evaluated to make sure they still apply in this changing world. Innovation is sometimes faster than regulation, so it's a tricky space for those that are pushing the boundaries of conventional thinking. So just like you work really hard to create great patient experiences, you can easily substitute staff experiences in the same context. Our office is about 20 minutes from Niagara Falls. We know a thing or two about aerosols. But in Ontario, we're still in a state of emergency with dental clinics just reopening now. And there's much discussion, there's much worry and conflict about what is the safest way to practice, and what's the best way to care for patients' mounting needs. There's conflict between the dental and hygiene regulators, and they're struggling to find alignment in the best practices to protect the public and the healthcare providers and their teams. I'm sure it isn't easy, but we're fortunate to be among one of the last provinces to open, because there's a lot to be learned from the experience of clinicians in Europe, the US, and other parts of Canada. One of the greatest mismatch of expectations is around the use of non-aerosol producing procedures, like using hand instrumentation alone to try to deliver optimal patient care. I have nothing against using hand instruments, but using them exclusively sort of ties your hands in taking care of patients. In our clinic, we have 5 hygienists who use ultrasonics and guided biofilm therapy all day long. Our patients are referred to us because they have severe periodontal disease, which has not responded to a conventional care. Just using hand instruments alone for a periodontal clinic is not a reasonable choice. Sometimes you have to get a little bit messy. Sometimes you have to create a problem to solve a problem. And generating aerosols is just one of those problems. We need to figure out how to do this safely.
Most of the safety discussions revolves around aerosol production and the fact that dentists are one of the most aerosol-producing professions in the world. Nearly all dental instruments used in common treatments generate aerosols. You have low and high-speed handpieces, you've got turbines, you've got sonic and ultrasonic devices, you have air-water syringes and air polishing devices. The only profession that produces more aerosol through clinical treatment are dental hygienists. You can see this here on the chart. Interestingly though, since the advent of universal precautions decades ago, it's extremely unlikely for a dentist or a dental hygienist to get sick from a patient during a dental visit if they follow the public health rules that we were always supposed to be following. So COVID-19 comes along and scares everyone because of the known unknowns. Coronaviruses have been around for more than 100 years. But until we know more about COVID-19 and the SARS virus, we need to be careful, and that's fair.
You're likely to get sick if someone with COVID-19 coughs or sneezes on you, or if you touch something that's been contaminated by the virus, and then you touch your eye, your nose, or your mouth. COVID-19 is not going to enter your body through your fingers. Wash your hands thoroughly and often, and that's a good practice even when not in a pandemic, but you know that already. Dental aerosols can present a health risk, as the virus can be detected in the area of the mouth, nose, and throat. The main transmission path is through droplet infection, and recent studies show that the transmission of SARS-CoV-2 via aerosols in normal social settings can't be excluded. So wear a mask for now if you can't social distance. Aerosols differ from droplets and spray mist due to their smaller particle size. They can be carried several meters away, and they can be detected in room air for up to 30 minutes. It's not to say the virus is going to be there, but aerosols are known to do this. Scientists tell us, and I'm paraphrasing, even if the virus had wings and stayed in the air, the dilution of the virus by way of an open window or an air filtration system reduces the amount so severely, it's not reasonable to conclude that you're going to get sick this way in a dental office. But we don't know for certain, and until we do, people are going to be very scared. People form your team or your company, and your team or your company is really nervous. So really, companies are just a group of people. People are excited, learning, progressing, moving fast with adrenaline, so is the company. If the people are misinformed, going different directions, scared, not knowing exactly what's happening, doing different things in an uncoordinated fashion, the company stalls. Your people are critical to your survival as a business, and you must know that and must respect that. In fact, your people are the only thing that your competition can't copy. And people aren't assets. You're not comparing them to the tractor or the building. People are your business. They react. They're the emotion of your brand. And these are very emotional times. They are working very differently than they did 15 years ago.
A friend of mine, Brad Chedister, he's a warfighter systems architect at Draper Labs in Tampa. It's the coolest handle you could ever imagine, warfighter systems architect. Enhancing the warfighter of the future is his role. He designs Iron Man suits, but for real-life combat situations. I'm designing PPE combinations to combat aerosols. Yeah, same difference. His role is enhancing human performance through technology. And he uses a term when he looks at his team. He calls them meat bags of performance. Brad says the soldier of 10 years ago would absolutely have no chance against the warfighter of today. Why is that? It's because you need to change your viewpoint on how things are supposed to be. You need to explore and be the insurgent, not the incumbent. I'm thinking of changing my title of periodonist to plaque fighter systems architect. This little gizmo that you see in the corner is a particle counter, and I'll get to that in just a minute. Another known unknown. With COVID-19, the exact amount of virus needed to make you sick is not known. But for the sake of discussion, let's be extremists together and assume you just need a really little bit. Okay, with that, let's move to a parallel universe and assume for a moment that COVID-19 could be transmitted from a patient in an aerosol in a dental operatory. How do we strategically design our personal protective equipment, our dental Iron Man suit, and our clinical procedures to avoid this risk while still providing the best care for the patient? The last thing we want to do is offer mediocre or ineffective therapy because we don't understand the risk properly. That's wasting everyone's time. So I decided to conduct an experiment where I measured the aerosol particles produced during a dental procedure and evaluated the best way to reduce these aerosols. The greatest particle producing treatment in my office is the use of ultrasonic instruments and guided biofilm therapy, or GBT, using airflow technology for supportive periodontal therapy. Basically, what GBT involves is using a powder jet reaching more than 400 kilometers an hour through a special handpiece by a company called EMS. This energized spray of water and powder collide on the surface of the tooth to break up the biofilm in an extremely effective manner. It's very efficient to use, has excellent ergonomics, is easy to work with for hours and hours, unlike hand instruments, and when you use it with disclosing solution, you're actually targeting the areas that need biofilm disruption, rather than chasing an invisible coating. Best of all, it's far more comfortable for the patient, and the clinical results are simply excellent. I can't imagine practicing without it. So it was non-negotiable that we abandon GBT for hand instruments and a monojet syringe in the name of aerosol avoidance. You wouldn't use a knife to clean your car. Why would you use that on your teeth? The downside to GBT is that it's among the most aerosol-generating procedures in dentistry. But if we can control aerosol production with this procedure, it would be applicable to the rest of dentistry. So let's look at the internal evidence and what we can achieve in private practice. Game on. So this is what we did.
I enlisted my immediate family to be the first patients to have their teeth cleaned in my practice since we closed 12 weeks ago due to the pandemic. I have a particle counter that measures air quality. Specifically, it measures particles that are less than 2.5 microns. The instrument is a Temtop 1000, and it's useful to study the air quality in your office. The PM 2.5 refers to fine particulate matter, which is the general term for all small particles found in air measuring equal to or less than 2.5 microns in diameter. It's a complex mixture varying in size, shape, density, surface area, and chemical composition. Indoor PM 2.5 is composed of indoor generating particles from sources such as smoking, cooking, frying bacon, candles and fireplaces, and cleaning products, and particles that have come from the outside. In studies conducted by Health Canada in different Canadian cities, the average indoor PM 2.5 concentrations are less than 15 micrograms in homes without smokers and less than 35 micrograms in homes with smokers. In the United States, the EPA established national ambient air quality standards for PM 2.5 to be protective of public health. The short-term standard, or daily average, is to be less than 35 micrograms. So putting this together, if you want to be breathing indoor air that's safe, it should have a measurement of 15 or less.
In my clinic, we have a centralized and fairly sophisticated air purification system. All of my operatories are negative pressure, and the air exchange is once every 3 minutes. All the air in the office passes through 5 HEPA air filters, a UV germicidal irradiation light, and a plasma filter. So it's a bit of an overkill, but I'd rather overkill than simply wound the germs and make them mad at me. So welcome to my office. This is what we did last Saturday. I brought in my family as the first patients after the pandemic, and we did a soft opening. Here you see the HVE just being removed, and the particle counter is adjusting, and after a few seconds, we're able to see the particle counter picking up the aerosol from the airflow unit. As the HVE is returned, it goes down suddenly, and we're able to reduce the aerosol production. Now we did this in a bunch of different rooms. Here is an aerosol that's being produced without high volume suction. This is how we used to do things, just using a mirror suction and a saliva ejector. But look at how much aerosol is being generated here. Now of course this is not virus coming out, this is simply aerosol. But it gets really, really high nonetheless. So clearly this area would benefit from a high volume evacuation apparatus of some sort. And there are lots of gizmos and gadgets that are available, but we wanted to be very simple, so we used our 8mm bore high volume suction. Here's another example. The HVE is removed, the airflow continues to operate, and a little mistake was done here. It's pulled out of the mouth, and the aerosols are fired into the air, and we can see our particle counter really quickly picks up on this. And as the HVE is returned, the numbers come down again. Here we see the HVE being removed, and the particle count immediately rises. So once the HVE is removed, the particles are in the air and it's too late. Then we're relying on secondary mechanisms to collect those particles, be it the air filter, be it the standalone purifying system that you have in your office. But really, you want to collect the aerosols before they leave the oral cavity. And the way to easily measure if you're effective at that is by a handheld particle counter. And we can notice that the particle count is actually lower close to the patient due to the high volume suction than it is further away in the room. Here the HVE is removed. We're sitting at about 3.2, which is very, very good. And then as soon as the HVE is removed, the particle counter goes nuts. As it's reapplied, it comes down again. So we can see that four-handed dentistry, four-handed hygiene, it makes aerosols undetectable extraorally. It's not the only way to do it, but it's one way. Here we're holding the particle counter at the face level of the clinician. And she's simply using a mirror suction and a saliva ejector. And over the next few minutes, you will see the particle count rise at face level for her. Now she's wearing an N95 mask and a face shield, but over time we see here that the particles can get very close to face level. Particle count comes up to unhealthy levels, and right now the high volume suction is off. When the high volume suction is returned, you can see the immediate reduction of the particle count at the face level of the clinician. I should also mention that I'm not wearing gloves because this is my family and we drove together to the appointment in the same car. I mentioned internal and external evidence. Internal and external evidence is used by clinicians to validate or dispute clinical treatment options for our patients. The external evidence comes from peer-reviewed studies, both laboratory studies and clinical studies. It comes from academics and institutions that you can really rely on. The limitation is that some studies are conducted in unrealistic or impractical conditions that you can't simply simulate in private practice. It's just not reasonable. The internal evidence comes from what you do in clinical practice every day. It forms the evidence that gives you the confidence to say, I can actually do this. I can make this work in my hands. It relies on technology to a point. It relies on experience and how you can approach things to do the best for your patient, giving your personal practice setup. But it's the internal evidence what I'm going to present to you today. To adapt to the new world, you can either optimize what you're already doing or explore a new way. You can be the incumbent or you can be the insurgent. Sometimes only the paranoid survive. And it's this constant balance between this optimization versus exploration. So our best strategy as dental professionals to demystify this aerosol-causing problem is first, you want to screen patients the day before they come into your office over the phone. Never before in dentistry has the administration team been so important. They're responsible for the first line of defense. And if a patient screens positive over the phone, have them call public health and suggest they get tested. I wouldn't recommend seeing patients who screen positive for COVID-19 unless it's a dire emergency. Screen them again before they enter your office. Wash your hands. Make sure your team washes their hands and washes them often. Have the patient wash their hands when they come into the office after they've been screened. You're going to go through a ton of hand sanitizer, but boy, it's going to be worth it. You want to move to a low-touch dental office. The less stuff people touch, the better. Now is the perfect opportunity to declutter your office and get rid of all that old crap that's been sitting around forever. Every obstacle to digital transformation is now removed. So now's the time to get rid of the paperwork and enter the digital world. For now, anyone who enters the office should be wearing a mask. That includes your staff, your patients, and you. And you don't remove the mask unless you're eating, having a filling, or going to the restroom. Have the patient rinse with 1% hydrogen peroxide for 30 to 60 seconds pre-treatment. Equip your team with the PPE that makes them feel comfortable and conforms with the regulations in your area. You don't want them to overheat, and you want to have some consideration to being environmentally responsible. It would make sense that a hygienist or assistant wears a cap, face shield, level 2 or 3 mask, and a gown. This would be reasonable to provide optimal aerosol-generating care. And as for the chief meat bag of performance that's also known as the dentist, well, they should probably be wearing the same. The use of a normal high vacuum suction system with a suction volume of at least 300 liters per minute is required to optimally reduce aerosols. Four-handed dentistry allows optimal suction and should be considered as part of the normal routine. Now, there'll be other gizmos and gadgets that do this, but they need to be held to the same standard as four-handed dentistry. In Canada, it's almost inconceivable for a dentist to work without an assistant to perform standard dental care for patients. This isn't the case in every country, however, and many dentists in some parts of the world still practice without a dedicated dental assistant, and I think this is really dangerous. Why? The reason is mostly due to economics. Well, the choice to provide the best possible care for the patient while keeping everyone as safe as possible can't be expected to be the least expensive choice. In every sector, mining, construction, agriculture, manufacturing, the easiest way to keep costs down is to ignore the safety of your workers. In dentistry, in Ontario, we've never done that. I believe we've demonstrated that four-handed dentistry does not create detectable aerosols outside the patient's mouth. Now, I know there are many gadgets that have been developed to minimize operatory aerosols, and that's great, but they need to be studied like our team has demonstrated here, and they should be compared to the current gold standard of the assistant holding the HVE in the patient's mouth before the aerosols escape the oral cavity. As we have demonstrated, once the aerosols leave the mouth, a secondary system is required to control them. I believe we have demonstrated that four-handed dentistry does not create detectable aerosols outside the patient's mouth. Now, to minimize the obvious expense associated with offering four-handed hygiene for perio patients, for example, we have partnered with two local hygiene colleges, Niagara College and the Southern Ontario Dental College, to have their senior hygiene students do an elective rotation through our office as hygiene assistants. The students get the experience of shadowing experienced hygienists, and we benefit from the extra hands. The patient enjoys the best of both worlds, and it's a triple win. But it's certainly not the best fitting solution for everyone, but it is one solution. I mentioned before that your company is your people. And your people understand dreams. They dream every night. Mission, vision, these things are hard to define and to articulate. And from benchmarking and comparing the guts of the most successful organizations in the world, there's a universal truth that's really simple. The people are better. So when you ask, why is their performance better? It's because the people aim higher and they dream bigger. They're selected and invested in. The people in the best businesses are simply more talented. The people feel the business or the practice they're in is their practice. It's not a job at a practice, it's their practice. But our people, no matter how outstanding they were before the pandemic, are likely struggling a bit. We all are, and that's probably normal. Given all the conflict between the changing regulations of the hygiene and dental colleges occupying our thoughts all day long, and the bombardment of hysteria from social media and the news all night long, and the worry about the safety of our families all day and all night, it's no wonder everyone is so stressed. We aren't controlling this pandemic. It's controlling us. So if we go back to what Viktor Frankl said, between stimulus and response there is a space. In that space is our power to choose our response. In our response lies our growth and our freedom. In that space, we have to understand that we are safe in our dental offices if we trust the external and internal evidence. We have to believe the science, not the opinions of noisy influencers. Clearly, it's not the same work it was 10 years ago or 10 months ago, and there's no post-COVID world. It's only before COVID and now. So as a leader, you need to make your team feel safe and equip them so they can do their best work. You need to reassure them that the aerosol production is undetectable if a high-volume suction is being used properly. Show them how important it is. If the patients are screened by your talented admin team, there's very little chance an infectious COVID-19 patient will be seen in the first place. Do you remember back in January when we would see dental patients we knew had Hep C, we knew they had HIV, and it didn't faze us in the least? It's time to remember how excellent our universal precautions were to begin with. Like most challenges, we can't do this alone, and we need our teams on board, and we need them more than ever. Our patients' problems aren't going to improve with time. We need to begin to serve again. So thank you for joining me on this journey. I hope you found it helpful. A very warm thank you to the members of my daytime family that helped me with this presentation. But of course, this is just the beginning. Our story today is our future history. It's been my privilege presenting this to you. Thank you for sharing half an hour with me. Oh, and one last thing. I hope you didn't find this presentation too intense.